Protocol-based management of hyperglycemic emergencies is essential to achieve successful outcome, and a number of guidelines are available which provide the specific guidelines in terms of management for DKA, including the ISPAD, BSPAD, and the ISPAE guidelines for management of diabetic ketoacidosis. So when we think about treatment of diabetic ketoacidosis, I think it's very simple. The major problem which is happening in terms of DKA is deficiency of fluid and relative or absolute deficiency of insulin. So the first step, of course, is to replenish that dehydration, and it's absolutely important because once we give fluids, it causes expansion of the volume and decrease in the counter-regulatory hormones, and that really decreases glucose by around 150 to 200 milligram per dl in the first 1 hour. This emphasizes the fact that we should actually defer insulin for at least that period, because giving insulin here will cause even rapid fall in glucose and would worsen the risk of hypokalemia. But since ketosis will not resolve unless insulin is added at around 1 to 2 hours of initiation of therapy, and this further decreases glucose, and subsequent to this one would expect the phase 2 take 60 to 100 milligram per dl per hour decrease with use of both fluid and insulin. Now we need to understand the timeline in terms of resolution of various parameters. So glucose typically decreases by 6 to 8 hours, ketones by around 10 to 12 hours, and acidosis by 14 to 18 hours in reasonably moderate to severe diabetic ketoacidosis. So there will come a time where glucose has resolved but ketoacidosis has not. So at that point, decreasing insulin or stopping insulin will cause worsening of diabetic ketoacidosis. So one needs to continue fluid and insulin and add dextrose, so there is a stable with fall in ketone levels. So there are basically 3 phases in management of diabetic ketoacidosis: initial hydration with fluid alone, use of insulin, and subsequently insulin dextrose in the subsequent setting. So where should we manage our patients with diabetic ketoacidosis? So it should ideally be managed with a center which has trained medical and paramedical staff in management of DKA, facilities for doing investigations, particularly blood gas and blood ketone, and if it is not possible, one needs to stabilize the child and refer to a higher center, because DKA is a potentially fatal disease if not managed appropriately. Children who have severe diabetic ketoacidosis, those who present below 5 years of age, and those who have altered sensorium should be managed in the ICU setting, while mild diabetic ketoacidosis can be managed either in the emergency room or on an ambulatory basis. The initial stabilization of a child with DKA is as for any other condition and includes the stabilization of airway using securing of airway along with nasogastric aspiration. Emptying of gastric content is important, particularly if there is an intake of sweetened drinks over the last few periods. Breathing should be stabilized, and particularly if an individual is in shock, oxygen may be considered at this time point. Intubation should be deferred in the setting of DKA because intubation can cause increase in acidosis in the CSF, and that may be dangerous. So unless the child requires intubation in absolute terms, one should avoid intubation in the setting of diabetic ketoacidosis. There should be 2 peripheral lines preferably put, with insulin being given with 1. Central line should be avoided because there is an increased risk of developing thrombosis in this setting. The assessment of the child in the initial phase is absolutely important and should include the assessment for hydration, which can be assessed using skin turgor and blood pressure. One needs to be cautious in terms of assessing dehydration, and it should be considered 1 step lower in this setting. Sensorium should be used using the modified GCS score for children. If a child had drowsiness or has low Glasgow Coma Scale at diagnosis, one needs to be very cautious about the possibility of cerebral edema at that point of time. So careful evaluation for the reflexes, for blood pressure, heart rate, pupils should be done. And if there is even a slightest doubt of cerebral edema, one needs to change the protocol in giving later slower correction of DKA over a period of time, use of mannitol at that setting. Conditions associated with hypokalemia at presentation are typically if somebody is treated outside without the use of potassium, and that's why one needs to be careful in any child with severe diabetic ketoacidosis about the possibility of hypokalemia. So ECG level should be looked at, and if it is suggestive of hypokalemia, one may actually defer insulin therapy till the levels are available. Current weight and height should be measured, as the weight will help us in terms of diffusion of fluids, while body surface area may be required for older children. Urine output should be measured, and if required and if the child is unconscious, urine output should be measured using catheterization. Complete blood count, creatinine, urea and uric acid levels will help us assess the severity of diabetic ketoacidosis. Hydration status assessment is absolutely important in the setting of diabetic ketoacidosis. And often it is difficult to really assess dehydration, but parameters which are really helpful include the oral mucosa, capillary refill, skin turgor, pulses and blood pressure. And we need to basically categorize whether the dehydration is there if it's less than 5%, where everything is normal and the capillary refill is also less than 1.5 seconds. If there is 5 to 10% dehydration indicated by increased capillary refill time and reduced skin turgor, or a severely increased capillary refill time and turgor along with feeble pulses which indicates severe dehydration. Because clinical assessment of dehydration may be not appropriate in many situations, one may consider looking at lab markers like hemoglobin, urea, uric acid and protein insulin with anemia to assess the level of dehydration in diabetic ketoacidosis. One need to be very careful in individuals with DKA who present with shock, because as discussed earlier, counter-regulatory hormone excess does not really result in development of shock in DKA. So if a child with DKA presents to us with shock, a possibility of septicemia or a cerebral edema should be considered. Features of raised ICP like headache, bradycardia, hypertension, craniopalathes should mandate the use of mannitol and gradual correction. Hypokalemia, if at diagnosis, is extremely ominous sign and one should defer insulin and potassium infusion. Fever is unlikely in DKA, so if there is persistent fever, a possibility of antibiotic and infection should be considered. The fluid management of diabetic ketoacidosis is now being very simplified, and rather than the complicated regimens of the past, one needs to just consider the amount of maintenance fluid which is to be given along with deficit, and the correction is done over a period of 48 to 72 hours. With 72 hours reserved for suspected cerebral edema and severe DKA with hyperosmolality. The ISPAD guidelines talks about using the 4 to 1 ml law for using as far as maintenance requirement is concerned, with 4 ml per kg for the first 10 kg, 2 ml per kg for the next 10 kg and 1 ml subsequently. While the deficit is corrected using the dehydration level using normal saline. There have been concerns that giving too much fluid may be harmful, so therefore the British Society of Pediatric and Endocrinology and Diabetes has talked about even lower use of maintenance fluids with maximum of 40 ml per hour, which is substantially lower than the used in setting of ISPAD protocols. And they have really emphasized in the terms of use of pH as a surrogate marker of dehydration, with pH less than 7.1 being considered a marker of 10% and more than 7.1 as 5% dehydration. This is because there is a increasing thought that the clinical assessment of dehydration in DKA is not easy. In most situations, normal saline is the initial fluid, and whenever you are writing the fluid prescription for DKA, ensure that it is less than double maintenance, and usually it should be less than 1.5 times maintenance. The problem happens in heavier children, so body surface area may be a good marker beyond 30 to 50 kilograms, and which should be used for in terms of really deciding the amount of fluid to be given. The fluid bolus is not required in everybody who has diabetic ketoacidosis. It should be avoided unless there is tachycardia or shock. It is not for mild diabetic ketoacidosis. The dose is 10 ml per kg of normal saline, and it should be repeated if the shock is present. However, there is a restriction that we should not give more than 2 boluses, and the 4-hour fluid intake should not be more than 40 ml per kg. Insulin therapy is absolutely essential in management of DKA and is best given as an intravenous insulin, although IM insulin, as we'll discuss later, is a reasonable option. There is no need of giving any bolus in the setting of diabetic ketoacidosis, and the dose is around 0.1 unit per kg per hour. However, studies have shown that the use of lower dose in the form of 0.05 unit per kg per hour is equally effective in management of DKA with similar resolution time. The lower dose should definitely be considered in infants and those who have malnutrition in this setting. One needs to be cautious that as insulin can stick to the tubing should always be flushed, and the change in the insulin dose should be gradual, of around 10-15% rather than a dramatic increase, which often is done in this setting. In resource poor settings where intravenous infusion of insulin is not available, intramuscular, regular or rapid acting insulin in the dose of 0.3 unit per kg followed by 0.1 unit per kg per hour may be considered. Potassium depletion is a major problem in DKA, and with treatment there is further worsening of hypokalemia, and therefore one needs to be careful in terms of managing potassium levels in this setting. In individuals who have potassium levels less than 3.3 millimoles per liter, it should actually be added during the hydration phase at the dose of 20 millimoles per liter. When the levels are between 3.3 to 6, one has to add 40 millimoles per liter of potassium in the fluid, but if the level is more than 6 or there are ECG changes or N-urea, potassium should be withheld. Importantly, insulin dose should be decreased if the potassium levels fall below 3.5 millimoles per liter. As discussed earlier, treatment of DKA with insulin is associated with rapid resolution of glucose even before the correction of ketoacidosis. So there will be situations wherein glucose levels will become low but acidosis is persisting. So if the glucose is more than 300, there is no need of adding dextrose. If it's between 200 to 300, it's appropriate to add 5% dextrose, while if the levels are less than 200, 10% dextrose should be added. Early initiation of glucose is mandatory to avoid development of hypoglycemia. Alkali therapy is absolutely contraindicated in diabetic ketoacidosis because it is associated with cerebral edema. It can only be considered in the setting of life-threatening hyperkalemia or cardiac arrest and is given as 1 to 2 ml per kg as infusion. Careful monitoring of diabetic ketoacidosis is essential to identify the complication at an early stage, and one would expect improvement in sensorium, which should be documented using the modified GCS score. But if there is any worsening in sensorium, the possibility of cerebral edema or hypoglycemia should be considered. Corrected sodium levels should be stable. A rapid fall in corrected sodium should be a cause of worry and may be the first sign of development of cerebral edema subsequently. There should be gradual improvement of acidosis with resolution by around 12 to 16 hours even in severe cases. If it is persistent, one need to consider the possibility of infection, hyperchloremic metabolic acidosis or shock. Heart rate is expected to decrease with correction of dehydration, but sudden decrease should alert the possibility of cerebral edema. Urine output should be normal. If the urine output is below 1 ml per kg per hour, one need to be cautious about the possibility of renal failure. Ketosis should resolve with time, but if it is persisting, one should think of a insulin dose which is sticking in the tubing or a inadequate dose of insulin. Potassium levels should actually, if they are decreasing, one needs to be very careful in terms of reducing insulin and increasing potassium level. Persistent metabolic acidosis is a problem which often happens in DKA and is now happening even more with the use of sodium chloride as a correction fluid throughout the period. And this is because it can lead to development of hyperchloremic metabolic acidosis. So the major question which one needs to answer in terms of a child who presents with persistent metabolic acidosis with DKA is whether it is diabetic ketoacidosis, lactic acidosis or a hyperchloremic metabolic acidosis. So one needs to look at the ketone levels, which if they are more than 1.5, one should still consider that this is DKA. If they are less than 0.6, we should look at anion gap. If it is high, it is suggestive of a high anion gap, typically a lactic acidosis, while if it is low, it is most likely hyperchloremic metabolic acidosis, which is a self-resolving condition. If the renal functions are normal, there is no need to unnecessarily continue therapy in this setting. Cerebral edema is the most dangerous complication of DKA. Typically occurs with severe diabetic ketoacidosis as reflected by low pH, low CO2, administration of sodium bicarbonate and rapid fall of sodium. It usually happens 12 hours after treatment but can happen at any point of time. And the pointers include worsening of sensorium, development of cranial nerve palsies and increased intracranial pressure like hypertension and bradycardia. The condition should be immediately managed by use of mannitol and keeping the head end up and reducing the fluid to 60%. One should not wait for neuroimaging because that would be lethal in this setting. If the child is not improving despite these measures, one should consider the possibility of cortical venous thrombosis and hypoglycemia in this setting. Hypokalemia is an important complication which typically happens with prolonged disease and insulin excess. The pointers often include presence of polyuria, ECG changes or weakness, particularly myopathy, and it is managed with the use of potassium infusion and sometimes high dose infusion of around 0.5 to 1 millimoles per kg per hour may be required along with reduction of insulin. Persistent hypokalemia in a child with diabetic ketoacidosis should prompt to the possibility of hypomagnesemia, and correction of magnesium is usually associated with improvement in this setting. Rhabdomyolysis is rare in DKA but may happen in severe cases along with hypophosphatemia. Typically presents with myalgia, sudden onset pain in legs, weakness and dark urine. CPK level and creatinine levels become high. The condition is managed using dialysis and decrease in potassium infusion in this setting, and it is a real difficult situation to manage. Transition of diabetic ketoacidosis to subcutaneous insulin should be considered once the child has normal ketone and blood gas, sensorium is normal and the child is accepting orally. It should always be done with a meal, should never be done at midnight, which often happens in many intensive care units. If a child wants to snack, one can increase the insulin infusion rate to 50 to 100% depending upon the amount and duration of snack. It's always better to give a long-acting insulin like glargine one night before because that decreases the duration of diabetic ketoacidosis. The protocol involves decreasing the infusion rate to 0.05 unit per kg per hour followed by administration of subcutaneous rapid or short-acting insulin at the dose of 0.25 unit per kg, and the overlap of around 30 to 60 minutes between the administration of subcutaneous insulin and stoppage of insulin infusion. So management of DKA in a nutshell involves initial hydration phase of normal saline 10 ml per kg followed by correction of deficit and maintenance over 48 hours using normal saline with use of insulin without a bolus at around 0.1 unit per kg per hour, addition of potassium 40 millimoles per liter unless there is anuria or hyperkalemia, and addition of dextrose once the blood sugar levels become less than 300. Very importantly, sodium bicarbonate should not be given and cerebral edema should always be considered in any child who has worsening of condition and sensorium. The management of hyperglycemic hyperosmolar state is different compared to DKA in that the fluid requirement is usually higher and that results in decrease in counter-regulatory hormones resulting in decrease in glucose, and there is with just fluid there is a decline of the blood glucose by 100 to 200 milligram per dl per hour. Because one need to be wary about too rapid fall of glucose, insulin should not be added at this stage and it should be added only when the decline in glucose is less than 50 milligram per dl per hour, and the dose of insulin is also substantially lower with around 0.025 to 0.05 unit per kg per hour because higher dose are associated with rapid decline and significant problems in management. The aim of management of HHS is that there is a glucose fall of around 50 mg per dl per hour, sodium fall of around 0.5 millimoles per liter per hour, because if sodium doesn't fall, there are definite neurological sequelae which may happen with the overall correction over 24 to 48 hours. So the fluid management is basically starting with normal saline bolus, which is higher compared to DKA of 20 ml per kg, followed by 0.45% normal saline. The maintenance and deficit is to be corrected over 24 to 48 hours. The maintenance can be calculated via the 4-to-1 rule, and dehydration is usually higher compared to DKA to the tune of around 10 to 15%. Urinary loss, importantly in the setting of HHS, needs to be replaced with 0.4%, 0.45% normal saline as against DKA, where routine replacement of urinary loss is not required. The aim is to decrease glucose by around 50 to 100 mg per dl per hour and a sodium loss of around 0.5 millimoles per liter per hour. If there is a rapid fall in sodium, one needs to add normal saline in this setting. Insulin treatment is only indicated in HHS once the glucose fall is less than 50 mg per dl per hour or there is persistent ketosis or acidosis. The dose is low without any bolus of around 0.025 to 0.05 unit per kg per hour, and a precaution which needs to be done again is similar in the form of flushing of tubing and slow change in terms of insulin doses. So the management of HHS is different as compared to diabetic ketoacidosis in that the fluid requirement is higher with higher bolus and greater dehydration level, lesser requirement of insulin only when the blood sugar decline rate is less than 50 mg per dl per hour at a lower dose of around 0.025 to 0.05 unit per kg per hour, higher requirement of potassium once the hyperkalemia is resolved and the potassium is less than 5, closer monitoring for electrolytes, less requirement of dextrose which should be added only if there is a rapid fall, and careful stabilization. We should always be wary of complications of HHS, particularly venous thrombosis, and there could be consideration in high risk setting to start low molecular weight heparin, rhabdomyolysis, which characterized by muscle pain, colored urine and high CPK, and malignant hyperthermia, which is unusual but can present with high fever and CPK level. So to compare the management of diabetic ketoacidosis in hyperglycemic hyperosmolar state, individuals with DKA require lesser fluid with lesser dehydration correction over a longer period with no replacement of urine output which is required in HHS. The insulin is started 1 to 2 hours in DKA, while it is only started in HHS once the glucose fall is less than 50 mg per dl per hour, and the dose is lower for hyperglycemic hyperosmolar state. One needs to be very careful in terms of corrected sodium to stable in DKA while one wants it to fall by around 0.5 millimoles per hour, and there is a need for careful possibility of cerebral edema in DKA, while thrombosis and rhabdomyolysis are the major concern in HHS, and cerebral edema usually does not happen.